Hey guys, hope you're all doing well. We'll get started here in a couple minutes. We still have people joining in on the Zoom and people coming in person. All right, so for the people who are joining us virtually, we'll send the sign-in sheet here shortly. You must sign in and sign out to get credit. We will stop the sign-in sheet 20 minutes into the meeting, and we'll send the sign-out sheet 10 to 15 minutes before the meeting ends. All right, so we'll go ahead and get started. Thank you guys for being here. This is our third meeting out of 6 or 7 if you count the celebration. This meeting topic today is going to be neuropsychology. And we'll have a guest speaker come in at 6. So as usual, here are our membership requirements. Pretty easy to remember. You have to pay your membership dues, attend 3 out of the 6 meetings, attend 2 events. We'll have 4 this semester, and you have to submit 15 volunteer credits. We'll talk about the volunteer opportunities here in a little bit. And then again, if you're returning, your dues are 15. If you're new, your dues are 20. You can pay your dues here at the Venmo or Cash App, or in person. We accept cash payments as well. If you guys are ever wondering like what credits you've done or how many you need left, we have this personal attendance sheet. You can also message any of the officers. Just you can ask us where y'all at. Well, where y'all are at. But yeah, we can send this to you over PDF, or we have physical copies as well. And then this is our social media. The little QR code in the corner is our link tree. It has other like information, our membership requirements, our opportunities, our social media as well. We're probably most active on like Instagram, and the YouTube is really important to look at. If you ever miss a meeting, you can go on there and get the information still, since all of our meetings are recorded. And virtual people, if you want to pay attention to the chat, she just sent the sign-in sheet, so make sure to do that within the next 20 minutes. All right, so these are our March opportunities. We're wrapping up February. Our next event and our first event is going to be this Thursday. It's going to be an art therapy event led by Sarah Peters. She's a local art therapist, and we'll be doing expressive art. So that's our next event. If you signed up for the mental health training, that is this Friday. If you didn't sign up for it, don't worry about it. But for those of you who know what I'm talking about, you need to complete those modules before Friday. You should have received an email. You have to create an account. You have to email her back saying that you created the account so that she can enroll you into the correct module. So please, please, please get that done soon. There was only about 12 or 13 of y'all out of the 30 that have done it so far, or at least created the account. You guys haven't created the completed the modules yet. So please go ahead and start doing that. But yeah, that's what our March looks like. There is a slight typo on this flyer. Our next meeting isn't going to be over rehabilitation anymore. It's going to be over sports psychology. So if you guys are interested in that, we'll have a great guest speaker who's an expert in that field. So I'll have one of our volunteer coordinators talk about our volunteering.
Okay, so for our virtual volunteering, we have the letters of encouragement for SASH and the Children's Shelter. 1 letter counts as 1 credit. We also have an opportunity where you can actually donate some items, and then 1 item also equals 1 credit, and we can have that set up in the next tabling. Y'all can bring the items in the next tabling. Another opportunity is 7 cups, 1 credit. It's 1 credit per hour. It's like offering free and anonymous online therapy. There's also Love for the Elderly. It's 1 credit per letter or video. These are handwritten letters and recorded videos to the elderly. And then we also have the UTSA Pantry, 6 items. It must be actual items and not money. And then we also have SBA donations, $6 counts as 1 credit for a maximum of 5 credits. Yeah.
And then, yeah, our next in-person volunteer opportunity will either be March 5th or the 26th. And we're gonna get something set up with Morgan's Wonderland, so that will be most likely what we do next.
So if you're graduating this semester and you were hoping to get a cord, go ahead and scan that QR code. I will also send in the sign-up sheet after the meeting is over. It's just a short form saying, do you want the cord? Yes. We have our celebration meeting at the end of the semester where you can get recognized and we'll give you that cord. And then starting at 6, we're gonna have our guest speaker, Dr. Messerly, which I'll introduce in a little bit. For right now, we'll just do a couple icebreakers in the chat and in person while we wait for them to get here. They get a little lost. All right, guys, our speaker is here. I'll pull up her slides right now. How are you?
Good, how are you?
I'll move out of your way here in a second. We have a Zoom audience and an in-person audience.
Oh, okay, great.
So we'll be sharing our video, you'll be talking in here, and then we'll have your slides up here and in the Zoom in a second.
Okay. Hello. What do I have to do with like, how do I navigate like Zoom and the slides?
You don't really have to watch this.
Okay.
You'll just be like speaking into it. We'll talk. We'll
Oh,
get
and
the
you'll just
questions
click
from-
through it? Oh,
Yeah,
okay.
yeah.
I don't have to do anything. Oh, great, great, great. Okay. Sorry. I've never done like dual task before. I'll just kind of straddle this in case, and if I fall over, we'll know why. Yeah. Okay. Hi, everyone. Thank you so much for being here. Hello, everyone joining online. Can everyone hear me okay online? Will you guys message if you can't hear me? Cool. I'll just trust that you'll do that. So my name is Johanna Messerly, and I am a clinical perfect. Thank you so much. And I'm a clinical neuropsychologist at UT Health San Antonio, and I work in the Department of Neurology. Okay, so first a little bit about me. So I grew up in Wisconsin, and I went to college at Bethel University in St. Paul, Minnesota. It's a small kind of liberal arts college. And then I took a year off after my bachelor's in psychology, worked for a little bit, found out that you can't do a lot with a bachelor's in psychology. And then I went to graduate school in Fort Lauderdale at Nova Southeastern University. Followed by internship at the Central Arkansas VA in Little Rock. And then my postdoctoral fellowship is actually what brought me to San Antonio. So I did a 2-year focused neuropsychological fellowship here at the South Texas VA. And then my current position is as an assistant professor / clinical neuropsychologist, not neurologist, at UT Health. And then just kind of more importantly, I'm a big foodie. I love the food scene in San Antonio, been pleasantly surprised. I'm also an auntie to 2.5 little kiddos. One is in the oven right now. And then I'm just kind of a pop culture connoisseur. So a little bit about my journey. So both my parents are in the medical field. And so I knew that I wanted to work with people, and I knew I wanted to help people. And so I kind of assumed that that would involve medicine in some capacity. And so of course I did kind of the whole pre-med, tried out nursing, thought about PA school for a while, but psychology is really like where I found myself kind of sticking to and drawn to. And so I was able to kind of get out in 4 years with a bachelor's in psychology and a minor in biology, but I didn't have a plan with what to do. And that was pretty like unsettling to me because I love having a plan. And so kind of the year after college, I was working with in a group home, like working with some adults that have developmental delays and also pretty prominent psychiatric difficulties. And then I was working in an autism day treatment program, and I knew I wanted to go further. I wanted to kind of understand what my patients were going through and kind of how to help them better. And so kind of like serendipitously, my mom actually ended up working with a clinical neuropsychologist. I had no framework before this. And she calls me one day and she says, I think you need to meet this person. And so I sat down and met with him, and just from what he described, it was like kind of a light switch went off. I was like, this is it. Specifically, what did it for me, my hook, was he described a patient that had a history of traumatic brain injury that he saw for an assessment, a cognitive assessment, and then was conducting kind of rehabilitation services with. So he presented our testing data. He showed me how it mapped on to the brain MRI. And then he told me what he was doing in terms of intervening with this patient. And I was like, all right, this is it. Like, this is what I'm going to do. And so it's great to have hooks like that. And so from there, I applied to like a couple schools at kind of the last minute, got in, and then kind of everything took off from there. So kind of my current position right now, it's entirely outpatient. So like I said, it's in the Department of Neurology. And neurology is our primary consult source. So there's really kind of 4 main patient populations that we serve. So they involve movement disorders. So this is like Parkinson's disease, dystonia, essential tremor, maybe some atypical presentations, autoimmune conditions. So MS is probably the biggest one we work with, but we also see a decent amount of encephalitis, Sjogren's, lupus. And then we have a pretty robust epilepsy program with quite a few providers. We have an epilepsy monitoring unit where patients are admitted and observed, and they're taken off of their anti-seizure medication so that their seizures can be kind of characterized. And this is true of both like diagnosis and also for pre-surgical planning of, you know, if we're going to scoop out someone's brain, we kind of want to know where the seizures are coming from very specifically. And then I see quite a few older adults. That's probably the vast majority of my practice, where the question is always, is Alzheimer's happening to me? And then we also get a decent amount of referrals from primary care, geriatric medicine. I think that's probably the main one, but by and large, we're working very closely with our neurologists. And one of the things that I love about my position now is that I'm physically in the clinic, in the neurology clinic. So we have kind of a separate section in the back, but there's like direct in-person access to all our neurologists. And that's something that was a big priority for me, to just kind of have some interdisciplinary experience. Right, it's entirely outpatient, primarily assessment. And that assessment really is the bread and butter of a neuropsychologist. But recently I've been trying to develop some interventional services for our patients with these kind of chronic neurological conditions. They have broad cognitive concerns. They're getting in the way of their everyday life and their functioning. So their ability to kind of go to school and work, and just also getting in the way of their relationships. So trying to kind of come up with some different services that can help increase their functioning and their quality of life, as these people are living with diseases that they're going to have long term. And then I'm also the primary supervisor for our movement disorders rotation, because we have our own kind of postdoctoral training program in neuropsychology. So what a typical week looks like. Are y'all familiar with neuropsychological evaluations in a clinical? Okay. Could you skip to the next slide real quick to see what I have written? Okay, come back to that next one. Okay, great. So a person is noticing problems with their cognition. So what this might look like is they're noticing that they're forgetting conversations that they're having with other people. They're misplacing things around the house. Maybe a spouse or a loved one is saying they can't remember anything, and I have to keep kind of reminding them of things. A lot of people are concerned about memory in particular. That's often what kind of brings them in. But then some other kind of common concerns that people are reporting is they're having trouble coming up with the word they want to say. Like, it feels like it's on the tip of their tongue, but they can't quite think of it. Maybe they're noticing some changes with kind of how they're able to understand information as it's communicated to them verbally, or just with with reading comprehension. I hear about attentional difficulties a lot, like people have trouble with kind of staying focused on one thing at a time and not getting distracted by other things. They feel like they're losing their train of thought, where they're like, oh, what was I saying again? Or what was I doing? Or why did I come into the room? Just generally having trouble with kind of completing tasks that they need to do. They feel like their speed of thinking is slower, or they're having trouble with like making a decision, planning, or problem solving. Like all of those things is what brings someone in for an evaluation. So I'll meet with them for about 45 minutes to an hour, where I'm really like pressing into those concerns, like practically, what does that look like for you in your daily life? How did it start? When did it start? What has it looked like since it started? What does everyday life look like for you? Are you able to kind of manage your medications and your appointments? If you're not, what's getting in the way of that? How's your mood? Because we are clinical psychologists kind of first and foremost within the specialty in neuropsychology. So we're always, even though it's assessment, it's always therapeutic. And then also asking about like kind of all the things that can get in a way of someone's just brain efficiency, which is sleep, pain, their medical history, particularly seizures, stroke, or head injuries. I see a lot of people with some pretty prominent vascular health conditions, so diabetes, high blood pressure, history of substance abuse. So I'm going through all of that the hour before they test. Testing can take about 2 to 4 hours. So with the testing, the tests are given by a human. So we're not kind of sticking them in a room and asking them to do a bunch of like multiple choice questions. So all the things that I just said that I ask about, we attempt to measure, because our tests are thought to kind of map onto certain parts of the brain. So let me give you an example. With memory testing, there's a specific type of task called a list learning task. And this is where a list of words is read to the patient at this kind of standardized rate, right? Like maybe 1 word a second. And that's done several times. And each time the patient is saying it back. So we're looking at how they're able to learn that information. Then there's a break in the testing, and we do other tests. And then kind of out of the blue, we're like, okay, tell me all the words that you can remember from this test. And we're putting them on a spot very intentionally. And we're seeing what they come up with. And then after that, we're saying, well, was this word on the list? Was that word on the list? Because we're trying to kind of cue and boost their brain. That test maps onto kind of the middle part of the temporal lobe. So kind of this part that sits like right behind your ear. And that is the part of the brain that's implicated in like that initial part of Alzheimer's disease. So we want a test that's really specific to try to measure that part of the brain so we can detect any sort of early changes to help kind of provide clarification, and then also help get them plugged into services. So testing, like I said, takes 2 to 4 hours, and then I'll have feedback sessions with them later to kind of run through the results. I can do my own testing, but I don't. So I typically work with psychometrists, and these are masters, well, it could be some bachelor's level clinicians who are trained on giving the tests. And the testing for the training for this is extensive. So it probably takes like 8 weeks for you to like be proficient at giving these tests, because we need like a high degree of specificity and accuracy if we're going to say, hey, it's looking like you may have Alzheimer's, or you may have the beginning phase of Alzheimer's. We really need our tests to be given correctly. And so I see about 5 to 6 evaluations per week. So in total, an evaluation from kind of start of clinical interview to end of feedback, that takes about kind of 8 hours, because I'll typically spend about kind of 2 to 3 hours report writing, where I'm kind of bringing in all of this data from the medical record, from what I talked about with patient and family member, and then also the test results themselves. Do you want me to answer questions as I go? Okay, maybe we'll save them to the end. Okay, sorry. And then I see about 4 to 6 therapy patients a week. So this is a pretty specific type of therapy. It's called cognitive rehabilitation, where we're really just trying to work with people who have cognitive impairment and just try to increase their functioning and quality of life kind of within the midst of that. Okay, so this is an example of a patient that I see very often in my clinic. So Mr. Snow is an older adult, so he's kind of in his 60s. He has a 5-year history of Parkinson's disease, and he's being considered for deep brain stimulation, or DBS, and he was referred by his neurologist. So deep brain stimulation is where kind of like a pacemaker for your brain. So these electrodes are placed into very specific parts of your brain to help try to control the tremors, because the tremors can be pretty disabling with people that have Parkinson's disease. And so this surgery represents kind of an additional therapeutic option, because sometimes the medications don't always work very well for people with Parkinson's. They can have a lot of autonomic reactions, they can have visual hallucinations, or they could have a lot of impulsivity where they're maybe gambling or they're overeating, because we're dumping kind of dopamine back into their brain. And so that can kind of set off some kind of negative downstream effects. And so my question to answer as a part of this treatment team is to ask, is Parkinson's affecting his cognition? Because it can. And if so, what is the severity? So is there kind of objective cognitive difficulties that I'm seeing on testing? And does it seem like there's some other ongoing process? So is there, let's say, a comorbid Alzheimer's disease process going on? Because of course, the older you get, the more likely Alzheimer's is also going on. And then also assess kind of mood and psychiatric status. So are they experiencing things like depression, anxiety, or are they having kind of hallucinations? When did those start? Are they a part of the medication side effect, or is there something, again, something else going on? And then if they are present, how should they be managed? Does the neurology team feel comfortable managing those problems, or should we put in a referral to psychiatry? So I'll do my evaluation, and then I'll communicate the results to neurology and neurosurgery. So we meet once a month, and my job is to kind of answer those questions. And then based off of that, and of course, this isn't just the only thing, but it's part of the picture of what they consider is, do we want to have this person undergo brain surgery? And if so, what's our surgical target? Because surgical target can vary depending on if there's cognitive impairment present or not. Okay, so then in terms of the testing for Mr. Snow, these are kind of the domains that I would be looking at. So domains being kind of aspects of memory and thinking. So processing speed, just how fast his brain is able to make connections, attention and working memory. That's kind of the initial kind of receiving space for the brain. Our frontal lobes kind of take that all in and then decide what to do with it. So hopefully your attentional systems right now are like listening to me rather than thinking about what it feels like to sit in your chair. And then in terms of language, we're looking at kind of speech production and comprehension. Visuospatial is kind of how your brain makes sense of what the eyeball is seeing. We're looking at memory, which involves learning new information and being able to recall it later on. So kind of an input output. executive functioning, that's kind of the highest, the most complex aspect of cognition. So that involves planning, problem solving, kind of thinking through how to accomplish a bigger task in smaller chunks. So you think like as college students, you are handed a syllabus, right? And you're like, okay, this is when this paper is due, but we're not going to tell you how to do it. You know, if you want to wait till the night before to crank it out, that's totally up to you. Or, you know, if you wanted to kind of space it out a little bit more so that you're not kind of totally overwhelmed, that's an option as well. So that's something that your frontal lobe does. It says, do I want to hang out with my friends tonight? Or should I write this paper? I should write this paper. How am I going to accomplish everything that I need to do for all these different classes? So kind of like a multitasking, what's due when, what's going to take longer than other things. And then we also look at motor functioning. So kind of the big test that we use for that is we look at fine motor dexterity. So we ask patients to kind of pick up pegs and put them in another section. And then we're also looking at things like depression, anxiety, apathy, impulsivity, and then kind of integrating also what we're hearing from collateral report. And particularly, well, I would say in general, a collateral report is always helpful because we're often not the best judges of how we're thinking. We're also not thinking about how we're thinking often, but we're also not the best judges of our mood also, or just kind of how daily life is going for us. So generally, I like to involve a family member or spouse as much as possible. Okay, so we've completed the testing on Mr. Snow. He made it through. I received back a series of scores that are, if we're in a Word document, it's about a page and a half, and it's all scores of tests that kind of correspond to those areas of cognition that I was talking about. So as I'm looking at the scores, I'm asking myself some questions. So first is, okay, was the patient able to engage in testing? Some patients come in and they're super anxious about the whole process, which I totally get. It's really different. It's not something we do every day. And if you're willing to sit for a 4-hour evaluation, like you're pretty concerned about how you're doing. You know, this isn't like just a casual thing. So I've seen anxiety really get in the way of patients' ability to just kind of be present in the room. Sometimes people with like Parkinson's disease, they have pretty significant tremors and other motor symptoms like dyskinesias, where it kind of looks like they're just moving around involuntarily. So all of those things can kind of get in the way of testing if they slept the night before, if they took their medication, if they smoked weed just before coming in. That happened to one of my colleagues last week. And so what I'm asking is, are the scores I'm seeing valid? Meaning, is this an accurate, or do I think, to the best of my knowledge, is this an accurate representation of this person's cognitive abilities? And then I'm looking at patterns of scores. If I'm seeing a pattern of low scores, that might tell me that that part of the brain is having difficulty functioning. And it's also important to highlight strengths too. I mean, not everybody's kind of flatlined in terms of their function unless they're have just so marked dementia that they're in a nursing home. But generally you can tease out strengths and weaknesses, which I think has also helped just in terms of like intervention planning and helping patients and family members kind of understand what's going on. So then the next question I'm asking is, do these patterns fit with what I know about Parkinson's disease? So if I think about how Parkinson's disease specifically affects the brain, do these difficulties reflect that kind of underlying neurological condition? And if they don't, what else could be going on. Is there anything else that could be affecting the scores? So really like patient contextual factors like their education, and not even just like number of years of education, but their quality of education. So then you're kind of talking about socioeconomic status, their just their kind of prior functioning before this disease process hit. And then I'm asking kind of what are the severity of deficits? Are they kind of more mild? Would we expect the patient to be able to kind of cope with those on their own? Or are they to the severity where they probably do need more assistance in their everyday life? And then for Mr. Snow, it's what does the patient need to know about their diagnosis? So really clearly kind of communicating if there's cognitive impairment present, what severity is it? What does it mean? What's causing it? What do you do about it? What can you expect in the future? So these are pretty loaded conversations at times. And then what does the team need to know? So what does neurology and neurosurgery need to know? So it's different kind of patterns of communication that you're doing about the same evaluation. Okay, so this is kind of, if you decide to choose this adventure, this is what kind of your route would look like. So right now, to be a clinical neuropsychologist, you have to get the doctorate. So that would require at least 4 years of graduate school. So initially that looks like a lot of classes, but then as you kind of progress through the program, the classes taper off and you start kind of seeing patients as both a student therapist, because you do have to do some therapy, and also kind of learning how to do the assessments. So kind of like medical students, how they're doing their rotations and they're being supervised by attending and they're slowly given more and more responsibility. That's what a practicum student is. So that's kind of in addition to those classes, you kind of fit in your patients around your class schedule, which does get easier as the classes drop off. And then you're really doing research throughout. So you typically have a dissertation, which is kind of the peak of your research in graduate school. But through that whole process, you're maybe working with a research mentor to kind of look at poster publications, or maybe a literature review, or maybe you get like kind of put on a book chapter. So you're kind of multitasking all these things for 4 years at minimum. And then kind of at the beginning of your 4th year, I have to think about this timeline, you're applying for pre-doctoral internship. Are you guys familiar with the match process for residencies? Yeah, so it's a similar type of process. So you apply to these internship programs across the country. And then if you're accepted for an interview, you'll go on site for an interview. And then after that, you'll rank the programs, they'll rank you, and then there's a match day. I don't know what they're doing in the COVID pandemic era, but just to kind of let you know what I did. So I applied, I think, to, I can't remember. I think I had like 8 interviews and they were all over the country. So in the course of one day, I flew from Albuquerque, New Mexico to Augusta, Maine in January. And I had to take like 3 flights to get there so that I could go on all these interviews. I'm not sure if in-person interviews are gonna be around much longer, but it was definitely a character building experience. And so then I matched to the Little Rock VA. And so you do a year of pretty much entirely clinical work. So you can do some research and other things, other projects, but it's really just clinical work that is still supervised by like an attending But the goal, of course, as you progress through this is to get more and more independence with seeing patients. And while I was on internship, I did it all. So I did interview, testing, feedback. And then for your postdoctoral fellowship, so this is specific to neuropsychology. So this is a 2-year fellowship as opposed to other fellowships that are 1 year. So this is after you have your doctorate. You are applying for these programs in the same way as internship. So you're applying to them, they're inviting you for an interview. You interview at a conference, a national conference, and then you rank programs, they rank you, and you match. So then following your completion of that, then you can apply for licensure as a clinical psychologist, because I'm a licensed clinical psychologist. And then you can practice independently. In addition, the field is requiring more and more that neuropsychologists be board certified. So this is, again, once you're licensed, you have to go through a separate credential review of kind of all your training so far. Then you have to take a written exam, and then you have to submit 2 work samples, which are 2 reports for independent review. And then if you're approved, you sit for a 3-hour oral exam, but then you are done. Yes, and so I have not done that process, but I am in the process of it. So I'm just waiting to sit for my orals. So in terms of jobs, so when you do all this training, like where do you end up? So in terms of clinical setting, you can be in a veterans, a VA, a veterans hospital, or you could be in an academic medical center, which is where I am. Certainly you can do private practice, or also military. So there's a neuropsychology clinic here in town at BAMC that employs several neuropsychologists. You can be inpatient or outpatient. I would say the majority do outpatient. But one of my friends from fellowship, he does entirely inpatient work. So he's at the Shepherd Center in Georgia. So he works with, gosh, who does he work with? I think TBI and I think stroke. So you could make a career of just being in a hospital and kind of working with an interdisciplinary team. I like both. I have a lot of inpatient experience, and that's kind of its own thing. And then outpatient is also really fun too. And then in terms of research, you can publish, you can be involved in kind of more formal clinical trials. You can do forensic work. So one of my mentors here in town, his private practice is largely forensic work. So where you're giving kind of expert testimony. He's on retainer with many attorneys, giving super long depositions, but he likes it. And then also teaching is an option. So teaching can kind of take a couple routes. You can be kind of in a formal classroom, kind of traditional classroom, or you can be a supervisor in a training program. So that's what I do now. Oh, in terms of undergrad preparation, generally it's a psychology major. I think it would be important to kind of supplement that with maybe some more kind of rigorous science training. So statistics, biology, or neuroscience. I think it would be helpful to kind of have a little bit of background into some neuroanatomy, especially, and like with the statistics, there's required statistics classes, but if you're kind of wanting to like maximize your research, having that kind of foundation before you go into graduate school is just going to help you be all the more kind of independent and also creative. So kind of find the projects that you want to work on. I did not have a strong statistical background going into graduate school, and that totally fine. But I felt like I was kind of at the mercy of what was available, like kind of what had other people done, and kind of like I was checking a box. So if I had to go back and do it all over, I would have probably tried to emphasize that more in my undergrad. And then in terms of kind of additional involvement, I think getting involved in research, so finding a mentor here as an undergrad is a great option. Doing some sort of like clinical adjacent care. So like I worked at an autism day treatment center or group home. A lot of people in my graduate program had some sort of experience like that. But also some people went right into graduate school from undergrad. So if you know it's what you want, I don't think that you absolutely have to have that kind of patient care exposure. You could also be a psychometrist. So, I mean, a way to really see the tests in motion and in practice would be to be a psychometrist. And those are the people that are trained on giving the tests that I work with regularly. Professional group involvement, such as this one, and also just volunteering. So in terms of choosing a program, so I have a PsyD, which is a doctorate in psychology. The other option would be the PhD, so Doctor of Philosophy, with emphasis in psychology. The differences between those two are, they're not extensive. They used to be kind of, you were pigeonholed if you were a PsyD as being kind of really clinically focused. PhD was more research, kind of academic focus. Those lines have blurred kind of tremendously. I don't think a door is not going to be closed to you if you choose one or the other. I think there's different kind of emphases within the program itself. So if you're like, I really want to be a clinician and I really want to hone that, then maybe a PsyD is a better option for you. But also by that same token, if you go the PsyD route, that doesn't mean you're not going to get any sort of research experience. You're going to have to do research. And the same thing with PhD. Even if you're super research focused, you're going to have to see patients. In terms of a program, there needs to be some sort of dedicated emphasis in neuropsychology. And I think that's really important to look at up front. So I was in kind of a set neuropsychology track. So it had designated classes. And once I was accepted into the program, I was kind of automatically placed with one of the neuropsychologists on faculty. If there isn't a track, you want to at least make sure that there is faculty with expertise in neuropsychology, because you're really needing to get that strong foundation in both statistics and neuroanatomy and neuropathology. So those would be kind of the elective classes you would be taking. And then you want kind of availability of practicum site options. So those kind of medical school-esque rotations where you're in the clinic, you want that to be ideally with a board certified neuropsychologist who's training you on giving the tests, who's training you on kind of interviewing, report writing, kind of the nuts and bolts of that, so that you can be kind of the most competitive for your internship program. I did 1 year of therapy practicum, and then I did 2 years of kind of specific neuropsychology practicum. So you want to kind of make sure that there's availability of practicum sites. And I think this is really true because I actually just spent quite a bit of time looking at people that were applying for a postdoctoral training program. And you could tell that there were people who really had to kind of like claw their way through grad school to try to make training work. Maybe they realized that they were interested in neuropsychology kind of later on in the game. And so they had to kind of try to make something fit. And there's nothing wrong with that. You're just leaving a lot to chance. So if this is something that you think you want to do quite a bit of research beforehand before signing on to a program. See what research opportunities there are. So kind of that would be kind of more getting involved with that kind of specific neuropsychology faculty. And then location of program. So this is where you're going to spend 4 years of your life. You finished a bachelor's, like think about where do you want to live? Like what's a place that you would enjoy? What's cost of living like? So for example, there's a lot of great programs in Chicago, but that could be a pretty tough place to live as a graduate student. And so if that's a place you wanted to live, you might need to have like some sort of fallback plan. Are you going to work during your graduate school? If so, what are you going to do? What's kind of going to help you sustain you financially during those 4 years? And yeah, where do you think you're going to have kind of higher quality of life? Okay, why neuropsychology? I think that this field is so fascinating. So people are coming in and they're telling you about this unique set of difficulties. They're bringing you into their stories and they're saying, help me figure this out. And so every human is like a puzzle, right? So you start to get these like flavors and data points, and it's your job to kind of bring it together and synthesize it and like make it make sense for the patient and their family members and their care team in a really practical way. And so you have to kind of you have to be kind of curious and open to a little bit of ambiguity. And the thrill of that puzzle was really exciting to me. And the idea of kind of making a really like practical impact in someone's life was huge for me. And that's something that I enjoy all the time. It's not breezy all the time. Like it's a lot of work. Graduate school is a lot of work, internship, postdoctoral fellowship. This job is a lot, meaning it's kind of demanding of your kind of brain resources and your emotions and all those things. But it's fun. It's a lot of fun. And what does it take to be a good neuropsychologist? Again, this is kind of going off of all the interviews that I've done for postdoctoral fellowships. So these are people that want kind of that final aspect of their training. They're saying, this is what I want to do with the rest of my life. And so the people that kind of continuously impressed me and like gave me hope for the field was not necessarily people that had the highest credentials or had the most impressive CVs, but people that were easy to talk to and personable and like seemed to really want to do this job. Like we're really kind of passionate and committed to the field. People that were hardworking. I've seen a lot of bad reports and you can tell when someone is phoning it in. And that just does nothing for our field. It does nothing to help the patient. So there has to be like a genuine desire to like do good work and go the extra mile for your patient. So I think someone who is less about that kind of CV, more about someone who's curious, who has integrity, who's ethical, who is going to work hard, both in grad school and in their positions, someone who's good at communicating, someone who's also okay with a little bit of ambiguity, and yeah, just someone who's kind of excited to show up to work every day. because if this is something you're going to do for the rest of your life, kind of like having a baby, like you probably want to be pretty sure that this is a good thing for you. Yeah, so that's all I have for you guys. I don't even know what time it is, but yeah, I would love to answer questions.
There's a question in the group chat. It says, what age group do
I have
you
so
end
much
up seeing
groups.
that have issues?
Very quick.
I think that's your first one.
Oh, there's Mariah.
Hi.
What age
That's the
group
only
do
person
I
I
usually
like.
end up seeing that have
And they're
issues?
like,
All of them, all of the age group have issues, just in different ways. So I'll
Okay.
see some younger adults, and typically those, like I see
That's
a
the
lot of young
only
adults who
officer
have
that I
autoimmune
like from the
conditions like
Mariah.
MS, or traumatic brain injury.
I don't know
Or
either.
just
I'm
patients that are kind of coming in off the street and they're super concerned about their memory and thinking, but have no neurological history. Or people that have like pretty prominent psychiatric conditions. So they're also kind of noticing some troubles with memory and thinking. And then as we age, kind of more stroke, movement disorders, and Alzheimer's, just kind of older adults that are concerned about a dementia process.
Come on. I can't lift you. I can barely lift myself.
I don't know if you can still receive credit. I'm hoping the sign-in sheet got to you eventually.
yeah, I think I am. After that, Frank, I probably do need a fart.
What's the youngest patient I've seen? So I work with adults, but you can see patients as, I mean, I think some infants are getting kind of their cognition assessed. So yeah, I can tell you the oldest patients I've seen was 93. She looked better than me, so that was really unfortunate. Where did I receive my PsyD? At Nova Southeastern University in Fort Lauderdale, Florida. I think so, yes. No, go for it. No, I don't think I am.
You mentioned that you worked with the VA down here in Texas.
Mhm.
Is that the San Antonio?
Mm-hmm.
Is there any way of actually getting into the internship or getting, I guess, your foot into the door? That's the psychology student right now.
Like to have some sort of exposure to that.
Yes.
Probably not directly to neuropsychology. It could be maybe a route of like, I don't know, maybe like a CNA or some sort of like tech that you have on like some sort of hospital unit, maybe like the inpatient psychiatric unit to get some patient care exposure, but not really anything directly related to this. So you'd have exposure to maybe cognitively impaired individuals. But unless you wanted to kind of go the route of becoming a psychometrist, then you would be doing the testing.
There's like a program for that?
A psychometrist?
Yeah, somewhere around here.
So there's like no training program. It would be kind of a neuropsychologist saying, hey, this is a need that I have. And if you're hired, then we would train you. So we routinely hire psychometrists, and some of them have testing experience and some don't. Either way, like they're working under our license, so we're responsible for the work that they do. So if it's something that you wanted, it would kind of be up to that individual provider to kind of hire you and train you. But yeah, there's no kind of, I think there's a certification for it, but that's not a prerequisite to becoming a psychometrist. So anybody could do it. Yeah. Oh yeah.
remember. Sometimes she'll like call us different names.
Right.
Or she'll like cover events that happen with somebody.
Yeah.
So like, for example, like if you're a patient like, what would your cognitive like
Yeah. That's such a great question. So most of the work that's been done with cog rehab is been for someone with kind of like an acute acquired brain injury. So you think like TBI, that's the biggest one, right? Especially kind of with the war in Iraq, and all these soldiers were kind of coming back with concussions and even kind of moderate to severe TBIs. But more recently, there's been a focus on saying like, how do we intervene with individuals that have this kind of neurodegenerative condition, because they're going to get worse over time. There's no cure. Maybe there's some things we can do to kind of slow the decline, but they're on a path. So for that person, it kind of depends on how impaired they are. Generally, it's never about correction so much as it is like shaping the environment where they're living. So like, for example, a patient that I saw, so forgetful, like on testing, cannot remember anything. And it's showing up in his everyday life. And his wife is like, I'm going crazy. Like I cannot keep providing reminders to this person. And so we're talking about different ways to kind of help him function. So we have like, they have a whiteboard in their house, and we're teaching him how to use a planner and check that planner every day, and getting a little pill box to organize your medications, and use alarms on your phones to prompt you of that. Not that it's not going to solve anything, but like if we can give these people like some degree of autonomy when that all of that is kind of being like wrenched away from them, if we can kind of ease them into that process of saying, hey, you're going to need higher and higher level care, then that's what we need to be doing. It's kind of the same thing of like, okay, don't raise hands, but has anyone ever been like really stressed out and anxious? Right, don't, yeah. I've never had that happen to me. And someone says, oh, don't worry about it. And you're like, really? Thank you. That's so helpful, right? So instead of saying like, no, it's 2022, it's not 1922, it's like, hey, let's look at the whiteboard. Like, what do we have to do today? And this is our routine, and it's regular, and it doesn't put the person on the spot, right? It points them to what they should be doing, as opposed to kind of having them like turn the focus back on like, I'm broken and I'm breaking over time. Did that answer your question?
Yeah.
Okay, so the question is a psychometrist just a neuropsychologist that does specific testing? The psychometrist is supervised by the neuropsychologist that does the testing that the neuropsychologist kind of orders. So the testing is the same. So a psychometrist, you can't practice independently. You can't open a practice to be a psychometrist. They can only ever work with a neuropsychologist, and that is a doctorate level individual. So I hope that answers your question. Let me know if I did not.
So after your evaluation, and you're like writing their like treatment plan or whatever, do you write it by yourself, or are you like consulting other teams?
Oh, that's a great question. Yes and no. So it depends on what the patient is presenting with. So like, let's say with that example, if it looks like this person has an Alzheimer's disease, the question is, what do we do in daily life? And that's something that I would write, those recommendations. But then it's like, okay, how do we help them prepare for the future? How do we help them prepare for their decline? So then that would involve social work, where we're talking about like advanced care directives. So like, what do you want the end of your life to look like? Do you want to stay at home? Do you want to go to a living facility? What's kind of the bandwidth of the family to take care of that? like mental health, you know, depression and anxiety is just all the time everywhere. So there's always some sort of, like at least once a week, I'm sitting with a patient and saying, look, we need to kind of get you into something kind of formal treatment. How do we do that? What are some avenues? What are barriers in terms of access to care? Because there's just huge unnecessary barriers to mental health treatment. So then I might be kind of talking with one of our just clinics to see how we can get that referral placed. Depending on how straightforward the patient is, I may have to go back to the neurologist and get their opinion. So I saw a patient for a pre-DBS evaluation, young patient. Testing was really abnormal. So the part of your brain that processes visuospatial information is the parietal lobe. And her parietal lobe there was not a lot there. So there was not a lot of like brain tissue. And we were seeing that on testing. And that's super weird. This is a young patient. An essential tremor, which is what she has, you wouldn't expect to see that. So we saw those testing results. And so we emailed the neurologist and we're like, hey, I don't know, like we can't make sense of this. This isn't lining up. And so then they are kind of moving the ball forward with some additional kind of diagnostic testing. So you're generally always talking to someone. Yeah. So this is kind of going back to the psychometrist question. I would not say that a psychometrist is an assistant. They fulfill a really specific and needed role. The neuropsychologist can do the testing, but it's more like I can see more patients if someone else is doing the testing for me. So after I'm done with my interview, they'll do the testing and then I'll do other things. So they do the testing, I do maybe another interview, maybe I do a feedback session. So we're working together as a team. Oh, and then, do you notice an increase in anxiety and depression among younger people? I notice it among everybody. I think I was 9 months into my kind of independent practice when COVID hit. And that has just really like wrecked a lot of people in a lot of ways. So younger people, I mean, you guys are in college, like I don't know what years you are, but the pandemic has kind of touched your college experience in some way, probably not for the better. It's probably made your life more stressful. And that's not something you need as an undergrad. You've got enough to deal with. And then with the older adults, a lot of programs have been closed. And so, for example, like day treatment programs. So people who have these kind of maybe an Alzheimer's disease, like they need a place to go during the day. They can't be at home by themselves. So those programs just kind of shut down. And so then families were scrambling. And I think a lot of people lost kind of social interaction, which is huge for your brain. That's the best thing you could ever do for your brain. Socialize with people who are like actually good for you, not toxic people. But we lost that. And so that had some pretty huge effects on everybody of all ages, just kind of in different ways. Yes, it's very difficult. And I've had to kind of develop boundaries emotionally with that over time. I think when you're a trainee, you're so focused on like, oh gosh, I have to say like exactly the right thing. And so you're kind of self-monitoring. So you can't really be present with the patient. But then actually after my training, I was like, okay, I do actually maybe know what I'm talking about. And so I found myself being able to be more present with patients and their family, but then that kind of opened its own doors to like, wait a second, I'm really kind of taking on this. And so it's hard, but I try to remember like my role, like what does this patient need from me? They need me to be kind of as clear and as precise as possible. So, you know, it's not helpful to be like, I don't know, like, I don't, you know, like, I'm not sure. But if there is ambiguity, to explain that, like, this is what I'm seeing, this is what maps onto this. This is maybe something that doesn't quite make sense to me, but this is what we're going to do about it. So I think like remembering like my place within the patient care and like serving that need has helped me. Yeah, has helped me. But there have been some really tough sessions where families are like, it's not that bad, right? It's normal aging. And you have to say, no, this isn't. So yeah, it can be tough.
From like my perspective, this is like neuropsychology is like a small field.
Mm-hmm.
So is that like been a barrier to see it growing?
Oh, I hope it grows. I think our field can only grow if we get really good at kind of talking about how we can be useful. So like evaluations used to be like 8-10 hours. And so this is actually like, we've condensed ourselves quite a bit. And so saying like, we can answer some really specific questions and kind of take on some of the ownership of patient care that historically medical providers have been shouldering. So you think about like a neurologist who has had to kind of take on both the cognitive and mood and like make sure the patient doesn't have seizures anymore. So I think if we kind of show, hey, this is how we can be helpful and help you take care of your patient, I think that's really, in terms of the clinical setting, that's really where we're needed. And then I think our field is growing. We have at least one podcast, if anyone is interested. It's called Navigating Neuropsychology. It goes pretty in depth into some topics, but it could be interesting. So I think we're just trying to be more relatable. Is there a specific part of the brain that's been impacted by the patient's lack of socialization? I mean, I guess. So if someone is having kind of emotional difficulties, maybe I can like try to like backdoor this question. So if someone's having like emotional difficulties, that might point to kind of a certain part of the brain that's misfiring. So that would be kind of, your emotions are kind of housed in your limbic system, which is right next to your memory system. And so that's kind of deep inside the brain, kind of in the middle. And that sends kind of really strong signals to the front part of your brain, right? So your emotions can help kind of dictate how you make a plan. Like that example of that college student who's like, I really want to hang out with my friends, but I know that I need to study. And so our frontal lobes have to kind of balance between those things. And so if someone isn't getting that kind of like reward and reinforcement, I would say that maybe their limbic system is just having some misfirings. I don't know if that answers the question. No, I don't think so.
It's 7 o'clock, so through soon. But thank you so much for speaking. Actually, and
Oh.
for those of you who signed in here in person, you guys don't need to sign up. So thank you guys for showing up.
And I mean, I would be happy if you wanted to share my email with anyone that has any kind of follow-up questions. Yeah, everything. Thank you so much for joining.
Mariah or
need a lot of background info, and I think they did that, and we'll also send it to their parents, for sure. They always fill out the whole,
I know, same, yeah. Oh, thank you so much.
Thank
Thank
you.
you. No, this is great. This is so fun. I was so excited when you guys said you were interested.
Yeah.
She's telling Emily, like, I
Yeah.
So, yeah.
Just as many businesses.
So if you ever help or partner over there, like, that would be great. Yeah, if people were interested. Yeah. Oh, that's great.
Yeah.
Where are you headed after?
I don't know if they accept me yet, but I want to go there.
For what?
Like industrial organizations.
Really? Oh, that's
Yeah.
awesome.
So,
That'll be so
it
fun.
works out, yeah. Thank you guys for coming. Please sign out before I end this real quick.
Texas,
I'll send the sign-in sheets and everything you need after the meeting.
Alexis, wait. And she didn't hear me.